Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm back here again in London at the Centre for Perioperative Care's Perioperative Leads Day at the Royal College of Anaesthetists. And as we heard from our earlier session, one of the key themes for CPOC over the years has been about improving perioperative screening, looking at ways of moving that forwards. And there's been a whole session here at the meeting today talking about different screening approaches and potentially moving that to more digital approaches. And I'm delighted that three of the speakers have agreed to come and chat to us here on Top Med Talk. So again, if I ask you to introduce yourselves.
I'm Helen Andersen. I'm the Perioperative Lead for University Hospitals Plymouth.
I'm Ruth de La Casas. I'm again one of the Perioperative Leads in Norwich for the Norfolk Norwich University Hospitals.
I'm Dr. Neelaksi Desai. I'm one of the Perioperative Anaesthetic Leads in the clinic for Golden Jubilee National University Hospital, Glasgow.
Fantastic. Thank you all for coming in the break and chatting about all the amazing work you've been doing. I mean, open question to start with. I'm sure the discussion will spread from there, but why is screening such an important part of our work in perioperative care?
So I can start off on that. We found, going back to when the NHSE recommendations came out around pre-screening, at that time we were trying to take back some control, booking our pre-assessments. We found that over 80 administrators across the hospital could book into a preoperative assessment appointment, which meant when we were trying to get the right patients into the right slots with the right nurses in the right timeframes, it was just impossible. We had no oversight or control of that. So we essentially wanted to try and take back that control to get almost a preoperative clinic waiting list of our own and have some insight into that, so we could identify which patients needed anaesthetic input early on, which patients actually were pretty fit and well and appropriate for perhaps a telephone or shorter nurse pre-assessment, and which patients we needed to see to make those decisions on. By pre-screening, you can get a little bit of that information about what type of pre-assessment is suitable for that patient. And it also allows you to identify those optimizable factors that we're all trying really hard to work on, such as smoking, drinking, BMI, and get those early interventions up and running.
I think this is the place where we get the biggest win out of early screening, is allowing us to pick out the simple, straightforward green patients, as it were. And this is our way of trying to do more with the same resources that we have, which we know is a big push and part of the pressure of our expanding workload and increasing ageing population with more comorbidities. So we know there's a big tranche of patients who really don't need to spend a lot of time coming into the hospital to have all these things done. So if we can identify them early, it means that you're picking out a group that's highly unlikely to get postponed from pre-op, highly unlikely to get cancelled on the day of surgery. So we can focus our resources on those patients that require that involvement, that need the optimization, that need the investigations, and that need more time from our experienced staff to manage that.
I personally think that when Royal College of Anaesthetists came up with the fitter, better, sooner, I couldn't agree with them anymore, because our goal was always to find those patients who can be optimized even before they come to nurse pre-op assessment, so that we can liaise with the GPs and the other secondary care specialities and get those patients optimized, so when they come in, they don't get put on hold for a long time by the nurse pre-op assessment, and then we can reduce the waiting times for the patients. That was our primary goal.
And I think you've all highlighted some really important points, but points that are often forgotten. It's not just about selecting out the high-risk patients. Actually, it's just as important to select those patients that aren't as high risk and can go through. So I guess the next question that follows on from that is, what are the challenges to doing it well, and what sort of work have you all been doing at looking at ways to try and improve that process?
I think my main challenge was funding. And before COVID, there was some funding allocated, and we had to go through the competitive presentation process to prove it to the board that our project was going to improve numbers of patients going through pre-assessment clinic and reduce the waiting time. So ultimately, it was all about the numbers for the board. So we got funding before COVID, and then obviously during COVID, everything got reabsorbed back into the clinic. So then we had to start all over again. So that was one of my main challenges. Luckily, that group who does the prep has got a lot of support from the nurse pre-assessment and the anesthetist surgeons in the clinic. But my fear is that they are going to get taken away just purely because of the cost implications, and it's all about money at the moment.
Yep, certainly back up that. The funding's a challenge. I think for us, another thing that has been a challenge throughout is finding that point at which you get involved. So getting in early enough, essentially. We've found that building those relationships with primary care to be really difficult because everyone is working so hard. We've developed a digital screening tool, which we can talk about, but we want to be sending that out at the time of booking for surgery. You could argue that's too late, but that's as good as we've got. Even trying to get that out again when systems across the hospital at the moment is quite fragmented is trying to find that kind of common pathway of getting it to each patient early enough in the pathway to be effective, I think.
So we've been dealing with a lot of problems of we are a very digitally illiterate trust at the moment, but about to go through massive transformation from that perspective. So we've been trying to get in and see patients and deliver the screening questionnaire on the day that they're listed by the surgical team on a piece of paper, and then scanning it and then triaging it. So that's one issue. But then we also realise that that's great. We've made a plan for the patients coming to us now. How do we deal with the patients that are already booked? Because we want to try and select out the right pre-op appointment for the right patient. So we've actually been resorting to literally sending questionnaires out through the post, but that's been surprisingly effective. So we're getting about an 85% return rate, and it means that we can tackle the long waiters on the list who were listed, 6 months ago, maybe even more. We can get their information back. We can then triage them and therefore optimize the time that we spend on those that we need to and don't need to. So when there is a push to say, right, we need to look at our 65-week waiters and act on them, we've got an ability to be able to screen that patient population that has not been through the new world that we're trying to implement as well. And so hopefully these are things that we can continue to improve on and work our way to the digital solution, which hopefully will be coming in for July next year for us.
That's exciting. Okay. So we'll pick on that in a second, but just to step back and look at a bigger picture first. And again, to put this into a more international context, we're talking about the new world, the new visions. Obviously here in the UK, we're all very shaped by the political landscape and the recent publication of the NHS 10-year plan. Unsurprisingly, preoperative screening was highlighted in that, but also we talked about the difficulties in getting these patients soon enough, and that plan talks about breaking down the barriers between secondary care, primary care, moving care into the communities. Then it also talks about going digital, and it clearly sees those two things as happening simultaneously together.
I think it's part of the answer. I think that the sooner we can get information and an understanding about patients in our communities, the better. It may be that there should be a trigger to get these assessments and questionnaires in place from the point of referral at the GP. And having worked on a fit for referral process probably over 10 years ago now, just to check out what people's diabetes or diabetic control was like. Were they anemic? Were they in AF? We were raising those questions back then. It just sort of fell a little bit by the wayside. So now it's reinvigorating that process and hopefully liaising with our colleagues. These are chronic disease processes that they're involved in managing. We can identify if there's a problem, but we're not going to be responsible for their long-term management. So actually it's how we can work in partnership with our primary care colleagues, and between us we can help approach and improve this, as we know it's a point in time where patients are more open to behavioural change and improving their health and diet and things like that. So hopefully we get an opportunity to focus in early, and if we can get them at the point of referral, then it gives us even more time to manage. But at least if we get them at the point of consideration for surgery, we've then got that input.
And what sort of time periods are you looking at in terms of point of referral, point of consideration? Again, bearing in mind some of our listeners are international and won't be working in the UK health service.
And obviously that's very variable. It depends on the urgency of the surgery. But, for some of our patients being considered for joint replacement, unfortunately, we've still got very long waiting lists as a result of COVID and the delays in care for patients. So it could be up to a year. And it may be a year on the waiting list, that is, but it may be even more time than that, where there's actually been a consideration that surgery might be an option for these people. So if we could target right back at the beginning and say, well, actually, if you can keep moving, if we can sort your analgesia out, if we can get your weight management getting better, then actually you might get to a point where you don't actually need the surgery, potentially. And that will have benefits for you long term for all your chronic illness rather than just the joint replacement that's being considered.
So what sort of tools are you using in your trust at the moment for this screening process? And for people who might be listening to this thinking, how do we improve ours, or how do we take ours to the next stages? What sort of things should they be thinking about implementing?
We started a few years ago now with nothing. We were generally coming out of COVID. Our patients were being seen in pre-assessment days, weeks before their TCI, and we'd had no overview of them whatsoever. So we, as a group, decided to develop an in-house digital screening tool. There are kind of off-the-shelf versions available. The decision for us was to develop something in-house. We were lucky that our trust supported us with some digital IT funding time for that, and also some project management time. Key to that was having those NHSE recommendations around screening came out, and they gave us the leverage to get the funding for that, which was fantastic. So a group of anaesthetists and pre-op nurses developed a patient questionnaire. We ran a series of patient and carer events with that to help kind of inform us as we developed it. And then our digital team coded that, so that is now sent out to the patient at the time of booking. Embedded within that questionnaire, it's a medical history questionnaire. It's targeted towards what we felt we want to know from a pre-assessment point of view, but it's pretty broad-ranging. And embedded within the questionnaire is an algorithm which automatically puts patients into green, amber and red categories. For us as a large trust, that's crucial to have that automatic kind of triage, so that we're not having to have eyes on each questionnaire to decide what needs to happen to that patient. So the patients are triaged into those three categories. A red patient is someone who would then have an early anaesthetic assessment. A green patient is someone who would be appropriate for a shorter and nurse telephone pre-assessment. And amber patients are patients that we need to have seen by a nurse to make that decision about whether they need further anaesthetic input or are okay to proceed. The tool also then generates alerts on the factors that are appropriate for pre-optimization, so that we can intervene with those patients early in the process and get them onto appropriate supportive pathways as required. So that's the kind of core of our screening. I will hand over there to hear what others are doing.
That's actually really good to hear, because this is what we are lacking in our board. So in Scotland, we have got Scottish Care Information, that's called Sky Store, which is like a digital database which is visible to all the clinicians, and it's like single. So when the patient is seen in different boards for whatever reason, all the information, though there is slight delay, it still appears over there. And then every board will have their clinical portal. So we managed to develop our own electronic patient records, where obviously auxiliary staff and nursing staff and anaesthetists and surgeons, all the letters and everything is put. And then we can have a look at the other patient's clinical portal. The second thing, which I think is very important, is that the primary care and secondary care, they're working in parallel, but I don't think we can have a dialogue with each other, which is quick. It's all for us, it's always we are sending them letters, and it's then up to them whether they want to respond to that or not. Whereas I know for a fact that the primary care have got the task list and they can talk to each other via their own digital platform. I'm not sure in the 10-year plan with the government whether we can develop something where we can have a continuous dialogue between the boards and the primary care. And I think that's what will make a huge difference to patient care.
I think what you're developing is really exciting there, that your algorithm, I'm wondering how much you've changed that over that period of time, because I certainly have been involved in developing a screening questionnaire for the electronic patient record system that we're getting within our trust and within the Southwest Peninsula region, because that's been one of our sticking points, trying to work out what needs greater weight than others and trying to keep the screening as simple as possible so that the patients don't get bored. You don't want reams and reams of questions. You want to find the points that are and the conditions that are really the ones that make us think, actually, this is going to take a bit more time. These people need a bit more input. You know, from my feeling, it's things like that. We know that diabetes and anemia are very important, but to me, frailty is very important, and the weight management group, whether under or with poor nutrition or with obesity, both of those groups need help and support. And it's also how we can then target it to those people who are in the more deprived deciles, because we know that that's a group that's likely to have more problems and more issues. So how do we pull out all those different bits and pieces into the screening questionnaire so that we can use the algorithms to support us without increasing our manpower to look at it and review it?
Yeah, absolutely. And those are all the questions that we've been running through. And I think across the country, certainly across our kind of region, we're finding it. Everyone is trying to develop this same thing. And I think that's where these conversations are really useful. So one of the big advantages of it being in-house is that we have been able to be iterative with it and make those adjustments. So to the red, amber, green rating, we obviously sort of want to appropriately make as big as possible our green group and our red group, because the ambers are always that slightly unknown group. So in terms of the green group, for example, initially, anyone who answered positively to smoking or drinking, we made them an amber because we said, OK, they need some nurse input. But actually, when we reviewed that, that was a big group of patients who we thought, OK, actually, what they really just need is a prehab phone call. They don't necessarily need that full kind of nurse pre-assessment. So we actually then shifted that group of patients to green, but have that prehabilitation alert. So they get that phone call early on. So of all our patients, initially, we had about 9 or 10% of our patients who were green. And by making those little kind of iterative adjustments, we've increased that to about 15% of patients now who are green. And that's allowed us to increase our actual overall nurse pre-assessment capacity by about 5%, which has been brilliant. So similarly with the red patients, the other thing we did, and this was very experimental, but as we wrote the questionnaire as a group of anaesthetists, every answer that the patients give to the questionnaire, we gave a score out of 10. So if it's something really bad from our point of view, we gave it a 10. So, and if it's something we're not really worried about, we gave it a kind of 1 or 2. So if a patient's saying, yes, I have liver cirrhosis, then that would be a kind of 9 or 10 out of 10. If the patient says, yeah, I have asthma, but I very rarely use salbutamol, then that's kind of a 1 or 2. As I say, it was an experimental process, but it was the idea that with time, we might be able to use that score that then is generated, because we find we have our red patients who say yes to something quite serious like cirrhosis or dialysis or something along those lines. But then you have your patients who are amber in their category, but have said yes to lots and lots of things. So yes to heart disease, yes to heart failure, yes to diabetes, yes to COPD, but they're still amber overall. And we were fine. What we have done is looked at what we call our high scoring amber patients. So patients who fall into the amber category, but have given lots of positive yes responses and thereby generated a high score overall. I've gone through looking at which of those are then referred to an anaesthetic assessment. And we're just in the process of picking a score at which we say, you know what, these guys inevitably get referred for an anaesthetic assessment anyway, so let's see them automatically in anaesthetic clinics. Having that ability to play with the numbers is really exciting. Writing it all up is on my to-do list, but not quite there.
No, I think that's absolutely fantastic. I think it's that multimorbidity adds that extra layer of complexity. So each condition in itself may not be so significant, but when it's all parceled together, it means that the patient becomes more complex and needs more support and more input. That's a fantastic job. It sounds like you've been doing great work.
Could I ask you a quick question, Ruth? Does this app or the interface you're using with the patient, do you have any ability to give a message to the patient as well? For example, if a patient is coming for an operation in a week's time, could you send them a reminder that you need to stop clopidogrel, or you should not be taking Fluzin the day before, kind of thing? Because we have some cancellations on the day because patients have forgotten the instructions given to them by the pharmacist in the clinic. And that has got huge impact on our cancellation rate.
Yeah, so our digital kind of communication with the patient is actually kind of a fairly simple process. We use doctor-doctor, the trust used doctor-doctor. At the time of booking, as I say, a text message goes out to the patient asking them to fill in the questionnaire, and then they get a reminder 2 days later. We find on that basis, just sending out 2 text messages, that we get about a 75% completion rate. We're quite an elderly population, so we've been really pleasantly surprised by that. That's actually the only outgoing communication with the patient we have at the moment. Embedded within the questionnaire, we have put some prehab information. So things along, we had patients coming back to us who were, those frustrating stories you hear of a patient who has been on the waiting list for 1.5 years and then 3 days before their surgery told their HbA1c is and they can't continue. We had those patients coming back saying, if I'd known about this guidance, then I would have been more proactive in managing things myself. So we've embedded within the questionnaire. If you say, yes, I do live with diabetes, then some information pops up saying the national guidance is that your HbA1c should be XYZ. So touch base with your GP ASAP. And similarly for things like anemia, smoking and drinking. So we've embedded some prehab information in there. In terms of your question about clopidogrel, we don't do that at the moment. Obviously, every text message is money, but in theory, there would be the possibility to do that because we could run a report we don't ask for a drug history within the questionnaire, because when we did our patient events, the patient said that's going to throw a lot of people. It's going to put people off filling it in at that time. They're going to be waiting until they have their things in front of them and so on. So we don't take a drug history within the questionnaire, but we do ask them just, are you on any blood thinning or antiplatelet medications? Are you on any biologic medications? We give examples. Are you on we ask about kind of high dose opiates and things like that. So there is some we ask, again, those things that we feel we want to know about from pre-assessment point of view, but it's not comprehensive. So in theory, we could run a report to see which patients say yes to the antiplatelet message, and then we could send out a message regarding that. So there would be the potential, but obviously it would require the funding for the text messages to do that.
Brilliant. I do want to ask before we finish, you're all doing a huge amount of amazing work. There'll be lots of people listening to this within the UK, but probably around the world who think, I want to try and do that. How should they go about starting something like this? And I guess linked to that, more UK focused, why are we still doing this in silos? And you may not be able to answer this now, but I guess what's the next stage, kind of bringing everybody else forward onto this really exciting process?
I'm sort of hoping that's a bit about what today is all about, getting the local perioperative leads together as a group, and CPOC's work is about looking at how can we support us all so that we're not all inventing the same process, sharing of best practice, case reports, case studies. I think this is very much the CPOC's mission, to try and support us all with resources, information, and bringing together best practice and great ideas. So I think that's where I would signpost people to at the moment.
Yeah, I fully agree. I think it's so true. Regarding the silos, it's not self-imposed. I think one of the problems is that we all have different digital systems, and I think that's what it comes down to. So we now are really pleased with what we're achieving, but our trust will go on to EPR within the next year or so, and that may well cause a lot of challenges for all the work that we've done. In terms of even within our kind of East Anglian region, I am really happy to kind of share the work we've done, but because everyone has different digital processes, it's not possible. So I think that's where the problem is that fragmentation of digital processing.
I think that if you really want to make a change, then you just have to go in yourself and go for it. I personally talk to people, talk to surgeons, discuss things with anesthetic colleagues in CME, and then just push my agenda that way. Secondly, I don't think we have enough clinicians on the management level. If you look at the management structure, most of them come from the financial background and all. They look at the numbers and money. And I'm not saying that's not important, that's important. But if we want to bring out a change in the quality of care we are providing for patients, we need to have more clinicians on the management level. We are very lucky at the minute that we have got our assistant medical director is actually an orthopedic surgeon. And then he's been very instrumental in making few changes recently and giving us support all the teams. So we are already seeing change in our organizations very slowly but surely. So I feel if somebody is passionate about making a change, just take a first step and then the rest will follow.
Fantastic. Well, thank you all very much for your passion and inspiration and what you're doing already. I'm aware the talks have already started again downstairs. We should probably go back and listen. But thank you all for listening to us on Top Med Talk at home. As always, you can find us on social media, on our website, things like YouTube, LinkedIn, etc. If you do find us on those websites, please do hit like, hit subscribe. It really makes a difference. And thank you finally to our important sponsors who keep us free at the point of listening around the world, and this year that's BD and GE.
Top Med Talk.
Top Med Talk is the broadcasting arm of EdPOM, evidence-based perioperative medicine. Join clinicians from around the world at EdPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.